Good morning, everybody. Welcome to another wonderful Friday High Rounds. We have a visitor today, someone that was recommended by our dear friend, Dr. Darcy Wooten. So I think we should all be very excited about something and hopefully inspires many of us to think through some of our treatments a little bit differently. Dr. Madeline McCrary is a dual fellowship trained infectious diseases and addiction medicine physician and assistant professor of medicine in the Division of Infectious Diseases at Washington University in St. Louis, Missouri. Her primary focus has been developing novel programs to increase access to hepatitis C treatment for people who use drugs and pregnant people. So I'm sure she'll tell you more about what she's doing, but I will turn it over to her. And we're looking forward to this. Thanks.
Yeah, thank you so much for having me, and for giving us Darcy. She's wonderful. Um, but yeah, so I'll be talking about Hep C treatment in pregnancy, and my disclosures have been mitigated. Today we'll be discussing some background, some of the safety data, and then the evolution of our perinatal program at WashU, including a detour to talk about our Meds to Beds program. And then finally, we'll touch on our antenatal linkage to care program. According to the 2025 CDC Viral Hepatitis National Progress Report, while we're on track for reducing the rate of Hep C related death by over 20%, we're not meeting goals to reduce new Hep C infections or new infections among people who inject drugs. This JAMA article published in March looked at direct-acting antiviral or DAA course prescribing trends. And while DAA prescribing volumes are matching incident infections with about 69,000 courses per year, it's nowhere close to the volume estimated to be needed to achieve national elimination targets, which is about 260,000 courses per year. And while DAA prescribing has increased in primary care and non-metropolitan settings, suggesting efforts to decentralize Hep C treatment are happening, we need innovative strategies to screen, diagnose, and treat patients to close that gap and reach national elimination targets. Our programs at WashU focus on screening and treatment in areas where patients were already engaging in healthcare, but just weren't being offered these services before. And this includes prenatal care and then the hospital. National recommendations changed several years ago to recommend screening for Hep C during each pregnancy and then to link infected moms and exposed infants to care. Hepatitis C is rising in reproductive aged women, largely related to substance use, and is thus affecting more pregnancies. And in addition to causing liver disease over the long term for that individual, hepatitis C in pregnancy is associated with known adverse maternal, fetal, and neonatal events, including intrahepatic cholestasis of pregnancy, which is associated with intrauterine fetal demise and stillbirth, preterm labor, and perinatal transmission, which occurs in about 8% of hepatitis C monoinfected pregnancies. And this came out in a study in 2023, and the 8% is a lot higher than prior estimates. And they only saw transmissions in viremic pregnancies. Eliminating perinatal transmission of Hep C is now a U.S. viral hepatitis priority. Unfortunately, postpartum linkage to hepatitis C treatment is incredibly poor. Less than 6% of women with opioid use disorder and hepatitis C receive treatment by 6 months postpartum. We looked at nationwide insurance claims data, so more than Medicaid, include commercial claims, and found that less than 1% of women with hepatitis C, opioid use disorder, and a past year pregnancy were prescribed Hep C treatment compared to 5% of women with no pregnancy and 7% of men. So this is, pregnancy usually opens doors to resources, but in the case of Hep C, it's actually a barrier to treatment. Efforts to improve postpartum treatment include intensive co-location of OB, addiction and Hep C services, engaging women in labor and delivery, and OB specialty pharmacy partnerships. And these do significantly improve receipt of Hep C medications to about 50%. But these are single center, often resource intensive programs. And it means that about half of women aren't getting access to medications postpartum. And more often than not, I bet you these women are only being re-identified during their next pregnancy when they're screened again. And furthermore, postpartum treatment doesn't reduce the risk of perinatal transmission during the incident pregnancy in which they're identified. And so while these programs do great work and increase postpartum treatment access substantially, and protect future potential pregnancies and the patient themselves, antenatal treatment might help us close that gap. Exposed infants are also not getting screened. For example, among deliveries affected by Hep C at our hospital from 2020 to 2023, only 21% of exposed infants were screened, and we had a 10% perinatal transmission rate. And this study found that nationally, less than 50% of exposed infants are screened, and only a third of eligible children with actual perinatal transmissions are treated for the infection. CDC screening recommendations for exposed infants did change recently, and the effects of those recommendations weren't captured in this study. So hopefully that will help, but we're likely only seeing the tip of the iceberg in terms of the impact on children. And this is all a shame because many pregnant patients want treatment in pregnancy, or at least the opportunity for an informed discussion of risks and benefits. And there was a qualitative study on patient and OB perspectives on Hep C treatment and barriers in pregnancy that came out in 2022. And one quote from this paper that stood out to me was this: "One thing I wish would have happened somewhere along the way was that I would have been given treatment options." In 2022, the IDSA and AASLD updated their guidelines to endorse treatment in pregnancy through shared decision making. And this is a screenshot of the guidelines. It's not in a green box, so it's not like a direct recommendation, but the statement is there. There's no statements on treatment during breastfeeding, though I hear that might change to support it. However, the American College of Obstetricians and Gynecologists recommendations have not yet been updated, and at this time do not support treatment during pregnancy or breastfeeding. These recommendations on peripartum Hep C treatment from the TIP Hep C Community of Practice came out last July, and they capture the same things we know about Hep C treatment in the general population, which makes sense. And what it says are basically co-locating care helps, empowering frontline providers and providing technical support increases treatment access. Hep C treatment is largely access and care coordination. Minimizing delays in care increases DAA initiation, and it also supports shared decision making in the antenatal period. Evidence on DAAs in pregnancy and lactation has been rapidly emerging over the past several years. I'll present some of the data on the two frontline agents, sofosbuvir velpatasvir or Sofval, and glecaprevir pibrenizumab or GP. Both frontline agents have relative infant doses in breast milk far below the limit that is considered acceptable. A drug transfer study on Sofval was published in CID last year and found the estimated daily dose was less than 1%. We have a manuscript on GP under review at CID with similar findings. The limitations of these studies is that they, include small sample sizes and only included early breast milk. However, both frontline agents are highly plasma protein bound with low levels expected in breast milk per lactmed. And this data is reassuring and really show no safety concerns for DAAs in breast milk. And this is important as delaying DAA initiation until completion of breastfeeding, which is not really a defined time period for follow-up, likely leads to substantial postpartum loss to care. In terms of data on DAAs and pregnancy, I'll first cover some results from STORK, which is a phase 4 study looking at soft bowel started in the second or third trimester. There were two phase 1 studies published. One is HIP2, which is on soft bowel, and then there was HIP1, which was on sofosbuvir ladipasvir, and that preceded STORK, and they both contained PK data in pregnancy. And these slides are courtesy of Catherine Chappell from UPMC, the PI for Stork. And I just want to like really applaud, uh, Catherine Chappell has led all these studies on DAAs and in pregnancy, the clinical trials. And um, we don't see a lot of clinical trials in pregnancy. Like pregnant people are generally excluded from all trials, and that makes it really challenging. And so the fact that we have this clinical trial data is just really powerful. At the time of this analysis, she presented these findings at the liver meeting this past fall. There were 54 participants who had completed treatment and had SVR data. 96% of participants achieved SVR. There were two participants who did not achieve SVR, but they also like missed a significant portion of their treatment course. So it's not like only 96% were cured that took all their medication. And importantly, all participants had undetectable viral loads at 4 weeks on treatment. Most women delivered at term, and preterm birth rates were similar to, if not lower than that of the general population with hepatitis C who were not treated in pregnancy. Notably, no treated participants developed cholestasis, which has major implications in pregnancy, and no infants experienced perinatal transmission, compared to 8% among untreated pregnancies. This is just remarkable data, and we're really excited to see this come out, and it's expected that it's going to lead to some guideline changes. So what about GP? Well, we've been using GP at our institution as it's the Medicaid preferred Hep C regimen in our state, and I'll talk about sort of our program later. But we do have a manuscript under review at CID right now on a retrospective cohort of 10 patients treated with GP in the second or third trimester. There is an impact network study on GP and pregnancy. It's a phase 2, phase 3 study that just opened enrollment in the fall, but that's going to take a lot of time to get data out there. So we'll tell you what we know. So among the 10 participants, Hep C RNA has ranged from about 17,000 to 10 million. There were no Hep B or HIV co-infections, and no patients had evidence of cirrhosis. About 30% had prior pregnancies affected by Hep C, and the primary risk factor for Hep C was drug use, but one patient was from an endemic country, and about a third were actually not sure how they acquired Hep C. DAAs were initiated at a mean of 25 weeks, but ranged from 18 to 30 weeks, 31 weeks gestation. All had undetectable Hep C RNA at or by delivery. Of those we had data on, all had undetectable Hep C RNA on treatment. We usually got that around 3 to 4 weeks. They all had normal on treatment LFTs, and all who we had data on achieved SVR4 and SVR12. As you can see, getting SVR12 was pretty challenging, as we also experienced with non-pregnant individuals. And this is important because all the clinical trials are using SVR12 as an endpoint. But one thing that we're kind of talking about internally and with groups is whether we should be getting data on SVR4 because it's impossible to get SVR12 if it falls postpartum. So all pregnancies were delivered at term. There were no new episodes of cholestasis of pregnancy, gestational diabetes, or postpartum hemorrhage. There were no known infant safety concerns, and of the 6 we had infant screening on, there were no perinatal transmissions. While this was a small retrospective cohort of 10 individuals, the study is similar in size and outcomes to the phase 1 studies of SOFT-VAL and SOFT-LDV. And this was in a real world cohort that would probably not have met clinical trial participation criteria. very complicated past medical histories, and some with ongoing substance use. But the phase one trials that this retrospective cohort is similar to are the ones that prompted the changes to IDSA and ASLD guidance that allowed treatment in pregnancy through shared decision making. And when taking into account a meta-analysis, largely as sofosbuvir-based regimens, the Stork interim result, and the TIP-Hep-C registry, which collects data on exposures to DAs in pregnancy, and you should definitely enter any patients into. There are no known cases of perinatal transmissions that have occurred among patients treated for Hep C during pregnancy. And this is really important as it's a key motivator for parents wanting treatment during pregnancy, despite ongoing clinical trials and the limited information. Like, that's the number one thing we're hearing is just like, I want treatment because I want to do anything I can to prevent a transmission. And this also has key public health implications, particularly when there's challenges ensuring exposed infant screening and treatment at age 3. But all this makes sense. We know the same is true for other chronic viral infections like hepatitis B and HIV. Treating and suppressing the virus when detectable virus is required for transmission prevents perinatal transmission. So why wouldn't this be true for Hep C? All right, so now we'll talk about our program at WashU. Just for some background, Missouri is an End the HIV epidemic jurisdiction with 13 of the most at-risk counties for outbreak of bloodborne viruses. And this not only affects rural areas, but also St. Louis City, where the red arrow is. And in St. Louis, we face endemics of substance use, housing instability, and Hep C, among other related infections. As a referral center, WashU and our health system's flagship hospital, Barnes-Jewish Hospital, serves patients all over the state as well as Southern Illinois. In 2018, the Clinic for Acceptance, Recovery, and Empowerment opened. Care Clinic provides wraparound multidisciplinary services for pregnant patients with substance use disorders. Services include maternal fetal medicine, psychiatry, and perinatal behavioral health. They have relationships with neonatology. There's nurse navigation and peer support. And then in 2024, we integrated infectious diseases care. In July 2021, Missouri expanded Medicaid and entered into a subscription model to provide GP with no prior authorization, no cost to the patient, and we can provide a full 8-week course up front. Our perinatal treatment program has developed over time. And I'll preface this by saying this work was ongoing prior to my arrival to WashU in 2023. So I want to give enormous credit to Laura Marks, who has been a real driver for a lot of this change as is in our ID division. There have been several evolutions over the years. From 2018 to 2020, OB referred patients to ID, which is really like the default standard of care in most settings. In 2020, ID started doing telemedicine and chart review recommendations during the antepartum period, but only provided treatment postpartum. In 2022, we started bringing medications to bedside at labor and delivery. And then in 2024, we augmented these services by offering shared decision-making conversations in pregnancy and antepartum treatment. As I mentioned at WashU, all pregnant patients with substance use disorders are referred to a care clinic offering wraparound services. And this published analysis looked at Hep C care cascades among patients seen at care clinic before and after the implementation of ID telemedicine in 2020 with postpartum treatment. About 1/3 of patients seen in care clinic at the time had active Hep C. ID telemedicine included phone or video visits, as well as chart review to communicate treatment recommendations to the OB provider to prescribe themselves if the patient wasn't able to be seen by ID. So while ID consultation may be ante or postpartum, treatment was postpartum, and treatment was not delayed due to breastfeeding. Before telemedicine, only 14% of women with a detectable Hep C RNA started DAAs, and after telemedicine, 57% started DAAs. This analysis, however, did not look at treatment completion. It is important to note that more people initiated treatment than attended a telemedicine visit. And what this shows is that OB was prescribing DAAs based on ID chart review recommendations, And this is really important as it allowed OBs to get comfortable with prescribing Hep C treatment and to see its enormous benefits. Like the biggest cheerleaders of any of our programs have been this OB group. Um, and this is, really laid the foundation and set us up for success when we started talking about treating in pregnancy, which was new and, may make some people feel uncomfortable. In 2022,
Sorry, can I
OB,
just clarify a question from me
yeah,
on the slide before? So that means, is that how many pregnant people there were with hepatitis C? The 70 plus 154, or maybe even more than that?
yeah. So in the pre-period, there were 70 people, and then in the post-period, there
Ah,
were
150.
154 that were
Okay.
screened, and then 29 had Hep C and 42.
Sorry, that was the screening, and then I see. Oh, but that's
Yeah,
it.
yep,
So 42 of 154 screened were
yes,
RNA positive
yep.
who were
And that's
pregnant.
who actually had RNA testing. Sometimes,
Right.
like the sample isn't enough or, whatever for reflex
And
testing.
these seem like that's a very high prevalence.
Yeah, so it's about 30%.
Okay.
And, we see that like these perinatal substance use disorder clinics have a
Yes.
high, incidence of,
Right.
of
I
Hep
forgot that
C.
there
Yeah.
was the drug use component to this too. Okay. That makes
Yeah, yeah, yeah.
Thank you.
Yeah, no problem. Okay. So in 2022, we started bringing medications to labor and delivery. And part of this is that, like, for the telemedicine patients, it can be really hard to coordinate a specialty mail order delivery to folks and to get them meds. Our pharmacy was located in a separate location than the clinic. And so labor and delivery became an opportunity you knew where people were, you had their room number, and you could just walk across the street with medications. But what also started happening is that OB in L&D would start placing consults for Hep C. And so this allowed us to not only get the care clinic patients were part of that telemedicine program medications, but we also see a lot of people who don't engage in prenatal care or maybe engage elsewhere, but come to our hospital to deliver. And so this becomes a really important opportunity to treat Hep C in our perinatal substance use population. And of note, in this cohort, 87% of patients had prior pregnancies affected by Hep C. So this is a really vicious cycle where patients are screened in the pregnancy period, not treated postpartum, and then re-identified that we as a system just had not been addressing. So, bringing medications to bedside at labor and delivery improved treatment prescribing and known completion to 61% compared to 15% with standard referral to postpartum Hep C care. And of note, most patients did not show up to follow-up appointments or cure labs in the meds to beds group. So we obtained labs and information when they engaged in our health system at a later time point, whether that was from another clinic visit or really through acute care. So requiring postpartum follow-up, whether that's like for treatment or making sure that you can get cure labs, just really doesn't work. People just need access to medication. And we also found that even if we remove all barriers, so if we're sending people home with a baby in one arm and a full course, like all 8 weeks of DAAs in the other, we still struggled with medication completion and loss to care. And overwhelmingly, our patients during postpartum follow-up tell us that this is just a really challenging time. And adding one more extra thing, even if it's really desired, can be tough. It's also a time where there's a lot of mom-baby dyad separation and other stressors that might impact medication adherence or medication adherence. And so our pregnant women deserve and are asking for choices and when they get their Hep C cured. And while postpartum treatment has to be included in their options, for many, it's just not a feasible time frame. The success of this labor and delivery program actually led to the gradual expansion of medications to bedside to the rest of the hospital. And so I want to talk about this as well. And this program also did not happen overnight. It was built over several years, and we are still evolving. And so Laura Marks also kind of was the one initiating this. And this is really based off of, and same with the labor and delivery and our antenatal programs, off of a really strong collaboration with our ID clinic pharmacy. So in 2022, they started bringing medications to bedside to labor and delivery. And this seeped into the ID consult service team. So as you all, I'm sure, are aware, we see a lot of patients with Hep C for other reasons like septic arthritis, endocarditis, etc. And so started helping those teams coordinate Hep C treatment and bringing that to bedside. And in the fall of 2022 or 2023, I came to WashU and kind of brought on some more physician support. And then in early 2024, we implemented EMR-based routine screening. So we have a best practice advisory that fires on folks that have any kind of diagnosis code associated with a substance use disorder. It's a really blunt tool, so not totally specific, but it fires on a lot of folks. And we hired a nurse navigator to provide patient education, counseling, and linkage to care. And then in 2025, we hired a second nurse navigator, solidified our consult processes, and intensified our hepatitis C technical support to ID consult teams seeing these patients for other ID reasons. While many physicians provide these consults as part of the ID consult service when seeing patients for things like I mentioned, like septic arthritis, endocarditis, having dedicated Hep C physician champions within ID helped facilitate and standardize follow-up and care coordination. So much of Hep C care, at least in our state, is figuring out if there's a prior auth, what is needed for the PA, what pharmacy insurance requires us to fill the medication through, and then helping patients get that medication into their hands. So there's a lot of systems knowledge involved that kind of helps ensure patients are set up to be able to get medications. For the 2 years prior to implementation of our Meds to Beds program, our hospital post-discharge Hep C treatment rates can be best described as like an abject failure. Realistically, though, they're probably close to other institutions. So prior to implementing routine opt-out screening, we were screening still a lot of people for Hep C. So our institution had over 500 unique patients with Hep C over a 2-year period. Only 61% had any outpatient referral for care at discharge, and then only 7.6% were prescribed treatment within 6 months of hospitalization, with 4% achieving SVR. For comparison, there was a recent trial called the DETECT trial that provided active linkage to care resources for individuals diagnosed with Hep C in the emergency department settings. And that still only showed a 9% SVR rate in their population. So trying to get people into care post-discharge can be pretty challenging. Similar to pregnant patients who are universally screened for Hep C during pregnancy or at labor and delivery, we sought to standardize inpatient Hep C screening among patients. We focused on patients, as I mentioned, with histories of substance use through automated EMR-based testing and same encounter linkage to care, ideally with patients leaving with medications on discharge or meds to beds. So with meds to beds, we wanted to flip the script and change Hep C from an outpatient problem to an inpatient problem. And recall that in the 2 years prior to implementation of our program, there were over 500 unique patients with hospital admissions that included a positive Hep C RNA test. And that was prior to any routine screening initiative. And this means that we were testing people for Hep C during these admissions, spending money on the testing. So RNA testing is like, I don't know, $75 a test, and then doing nothing about it. And I also wonder if patients were even relayed the results of that testing. So this is just a waste of money. It's a waste of lab resources, and a lot of patients are uninsured. That goes to the hospital. So if we order a test, we should act on the result, especially when we have a cure. So Meds to Beds basically implements a test and treat approach, which is being widely adopted and promoted in the outpatient setting by leveraging hospitalization. Our nurse navigators are also amazing. So they see all these patients during their admission to provide education, counseling on harm reduction and medication adherence, and to gather information about treatment history, preferences, and barriers. And then based on that information, they then offer outpatient linkage to care or inpatient consultation for meds to beds. But realistically, like we are not able to see every single person in the hospital with Hep C. It's a lot of people. And so having these resources has been helpful to link the folks that we aren't able to see to care.
Quick question. The nurses are RNs, LVNs, something else?
RNs.
Thanks.
Yep.
Laura's answering the questions as you go, so it works out well.
Oh, perfect. Yeah. So
It's
the
a double.
nurses, for context, the nurses are currently funded by Gilead Focus program. But one thing, because hiring additional resources can be challenging. But I think with this slide, 43% of these patients were already being seen by ID for other reasons. And so this is something that can be done within the context of pre-existing ID consults. Um, but 57% of the consults were for Hep C meds to beds only. But these consults, and one thing we want to highlight is that they're billed to primary payers. So what we found is that our consults, when we did them, were typically being billed at a level 4 to 5. And so we have a dot phrase that includes all the information, counseling, and an MDM statement. So both Laura and I actually have FTE now because we were generating a significant amount of RVUs for these Hep C only consults. So most prescriptions are sent to our hospital RID clinic pharmacy. But if the patient's insurance prefers a specific mail order pharmacy, our clinic pharmacy will do the PA, and then we will send the script to whatever pharmacy our pharmacy tells us to send it to. And then the patient will have their information at discharge to get the medication from the pharmacy themselves. So as you can see, we treat almost all Hep C scenarios in our Meds to Beds program with the exception of donor-derived infections, since those are typically deferred to hepatology at our institution. And then we also defer consults for patients with decompensated cirrhosis or hepatocellular carcinoma to hepatology as well, unless they ask for our involvement. But we're reaching a pretty diverse population. So people ranged in age from 30 to 56 years old. Almost half of patients were African American. 32% were unhoused at the time of DAA receipt, and 64% were actively using substances. Of note, 86% of patients were seen in the hospital within the prior year to DAA receipt, and only 24% were previously referred for Hep C care. We also were in the process of writing this up, and we found that like only 20% had any evidence of the chart. And granted, we don't have access to outside charts, but only 20% had actually engaged in any primary care in the 2 years prior to hospital admission. So this is a population utilizing acute care and really not getting referred to outpatient care, or when they are not having the ability to follow up with it. And finally, close to 20% of the patients that were identified were postpartum, and then there was a small percentage that were admitted to our antepartum unit and pregnant. So a decent number of patients are identified in the hospital in that perinatal period. Patients who received meds to beds were 54 times more likely to have an undetectable end of therapy hepatitis C RNA than those who received no resources. Patients who received intensive navigation with nurse navigators but no meds to beds consultation were 7 times more likely than those with no resources, but not close to 54 times. 98% of patients who were seen in the hospital were prescribed medications by 6 months of discharge, compared to 45% of intensive linkage to care and 8% in the no resources group. 71% of patients who received meds to bed had a negative Hep C RNA, compared to only 25% with navigation and just 5% of those with no resources. And it's not like 30% had treatment failures. We just weren't able to get SVR results on that group. These outcomes are comparable to the Opportunity trial and in a real world, much more complex insurance landscape than Scandinavia, where Opportunity happened.
Madeline, one question. I'm so
Yeah,
sorry. I'm
no
like in
problem.
it on the slide before.
Mhm.
The RNA not detected following initiation. What time period was that? Like when would you get it that it wasn't 4 weeks?
Oh, just any time on treatment.
Like if they were in the hospital, like
Yeah, we would try and get a Hep C RNA before they discharged if they
so they could
started
have
in the
been on it for
hospital.
like a few days? No.
Yeah, in theory. Usually
In
we wouldn't
theory,
check
yes,
that.
but sorry, I'm just going to add in since
Thanks,
I did those
Laura.
ones before.
Sorry.
That's okay. In theory, yes, it could be a few days, but the
Yeah.
vast majority of those on RNA are like week 7. So they got like readmitted for
Okay.
something else and they had 2, 3 days left of treatment. And we're like, let's grab it now because we don't know when you're going to show up back in care.
That makes sense.
And if
Okay.
they're negative then and we never see them again, then if they get reinfected, we're much more comfortable that a subsequent positive would be a reinfection.
Okay.
Yeah, we have the
Thank
approach of getting RNAs whenever we can. Um, uh, just because, yeah, like reinfections and that sort of thing. So yeah, great question. Okay. And so I think, the one thing that I think is just, especially when this is a rural epidemic, also, is that these programs can have enormous geographic reach when implemented in large referral centers. And so there's been that effort to decentralize treatment, but centralization can also be a tool that can be leveraged. And so we can do both. So you can see for those that received no resources, hardly anyone got DAAs within the 6 months, but people were located all over Missouri and southern Illinois. But then with intensive navigation, 45% eventually got DAAs, and people were mostly located in the St. Louis metro area. But meds to beds, almost everyone received DAAs, and they were all over. They were in rural Missouri, Illinois, like southern Illinois is quite rural, and then even Arkansas. So this can have a large geographic reach. But going back to perinatal Hep C, so as you recall, we were bringing medications to labor and delivery at our main hospital, and that was very successful. But it's also extremely resource intensive and time dependent as labor and delivery admissions are often brief. And we were only able to see like half the people diagnosed with Hep C in pregnancy due to those limitations and resources. Like we're not there over the weekend, that kind of thing. So we can only provide this service and the other issue is that we can only provide this service to people who deliver at our main hospital. We weren't going to other labor and deliveries. So we needed to have more options. So about 2 years ago, we started offering patients Hep C treatment in pregnancy through shared decision making. Our goal is to offer patients multiple time points to engage in Hep C care. And the information I'm about to present is part of a manuscript we're currently preparing, and the data is preliminary and not peer reviewed. But we'll see patients for an initial visit anytime in pregnancy, in person, in the hospital, or via telemedicine. The visit focuses mostly on education, discussing risks and benefits of each timing option, and then we offer expedited postpartum treatment and treatment in pregnancy. If they choose postpartum, we'll set them up for treatment. We can bring meds to labor and delivery if they come to our main hospital, or we can ensure that they get meds delivered to their home prior to birth. And then if the patient opts for antenatal treatment, we start medications in the second or third trimester, ideally after the anatomy scan, and we use the DAA preferred by their insurance. This is our workflow. We have an EMR report to identify patients. We run that about once per week. We then proactively reach out to frontline obstetric providers. And this program identifies folks across the health system. So if they engage in any, obstetric provider office in the medical group health system, we will capture them. And then we offer rapid and flexible scheduling. So we have clinics, we have our ID clinic, we have a co-located IDOB clinic, and then we do telemedicine, and then we can see people in the hospital during antepartum admissions. We have shared decision making, and then we prescribe the DAA preferred by insurance. Most pre-treatment labs are obtained during the usual prenatal workup. Sometimes there aren't LFTs to review, but we will order them that visit. But since we don't start treatment until 18 to 20 weeks, we usually have those labs back by then, or they're obtained for obstetric care anyways. Um, we use a FIB-4 and a patient history as a cirrhosis assessment, and then obtain a prior treatment history. Our discussions consist of three topics: Hep C education, including the need for exposed infant screening, treatment options and the pros and cons of each, and patient priorities. We discussed that there are adverse associations of Hep C in pregnancy, namely cholestasis and vertical transmission. But for vertical transmission, this has been like the primary reason people want to get treated. But we do reassure people that this really just means following baby, and many go on to clear the infection. Then, if they don't, we use the same medications to cure them once they're 3 years old. This is balanced by the limited safety data of DAAs in pregnancy. We discussed there's no signals of harm or reason to suspect harm. We just don't know. We discussed that data is limited but expanding, and there's ongoing clinical trials. But realistically, most medications aren't studied in pregnancy. But to mitigate that, we start in the second or third trimester and get labs on treatment, which we normally just don't do. Postpartum treatment is safe, but carries the risk of just not happening. Patients then express what their priorities are, and as I mentioned so far, patients seem to really prioritize the potential to reduce transmission risk. Even after we have to walk people back on this. We have to say, like, studies aren't powered to explicitly prove this. It's possible, but we just don't know. So still get your infant screened, or people prioritize safety. And then other things that have impacted people's decisions have been experiences with attempts to access treatment postpartum before and having pregnancies affected by Hep C, or, quote, just wanting to get it done. To assess the impact of our program, we did a pre-post analysis. We included pregnancies with a detectable Hep C RNA in at least one visit prior to 35 weeks gestation. The pre-period included 62 pregnancies identified between 18 months in 2022 to 2023. And then the post-period included 35 pregnancies from when our program started in March 2024 through August 2025. And one thing is that there were two individuals in the pre-period that accounted for two unique pregnancies each, so had repeat pregnancies with Hep C in 18 months. But all of the post-intervention pregnancies were from unique individuals who are also not part of the pre-intervention period. Our primary outcome is DAA prescription by 6 months postpartum. Some characteristics. So 80% are insured by Medicaid. About a third of patients lived in a zip code associated with a rural census tract. About a third had prior pregnancies affected by Hep C, and over 20% had limited prenatal care. The pre-implementation cohort did have more reported substance use during pregnancy, more stimulant use, and more patients that had opioid use disorder who were on medications for opioid use disorder. In the post-implementation period, as I mentioned, we identified 35 patients who met our criteria. We were able to reach 30 patients and had Hep C appointments where treatment timing options were offered, with 24 patients, or 69% of overall identified patients. And of these 24 patients, 18 or 75% preferred antenatal treatment. Of note, 54% of the Hep C appointments were by telemedicine, and the remainder were seen during OB visits in our integrated clinics or in the hospital. So no patients actually came to ID clinic. We tried having in-person visits in our standalone clinic, and that was completely unsuccessful. So we really had to meet people where they were. And our simplified approach to treatment enabled us to do visits by telemedicine and then to reach women across our health system. This cascade looks at Hep C treatment among those who attended a Hep C appointment. Of the 18 who preferred antenatal treatment, all received DAAs, but only 13 proceeded with treatment during pregnancy. So this differentiation is marked between like actual treatment timing and preferred, but ended up deferring by different shades of greens. The dark green are those who preferred treatment and actually treated during pregnancy, while the light green are those who preferred treatment but ultimately deferred. And reasons for deferral after receiving the DAAs was, well, one person didn't get them at all. Their insurance denied treatment until postpartum. And then the four others changed their minds after getting medication due to concerns over safety. And so this really highlights why these ongoing clinical trials are so important, but that doesn't mean we can uh, not kind of treat with shared decision making as we go. Of those who received DAAs, just overall, 92% completed treatment with 83% known to achieve SVR4. When we look at the effective treatment timing intention, those who preferred antenatal treatment were significantly more likely to complete treatment than those who preferred postpartum treatment, so 89% compared to 17%. But when we look at it by when people were actually treated, so some people, initially preferred antepartum but then deferred, those who were treated during pregnancy were twice as likely to complete treatment than those who have ultimately deferred postpartum. So that's 92% completed treatment compared to 45%. In our pre-post analysis, our program significantly improved DAA prescription by 6 months postpartum from 48% to 77%. And known treatment completion or evidence of SVR also increased significantly from 21% to 51%. Because intensive linkage to care efforts already existed at our main hospital, Barnes-Jewish, including like our beds to beds at labor and delivery, we wanted to stratify outcomes by whether patients delivered at the main hospital or at another hospital in the region where these services did not exist. While DIA prescription and treatment completion or SVR increased at the main hospital was not statistically significant. However, for patients delivering at other hospitals in the region, DAA prescription increased substantially from 14% to 73%, and known treatment completion or SVR increased from 11% to 50%. So this intervention effectively leveled the playing field for patients seeking care in the community rather than at the academic medical center. And this was also true for patients who resided in zip codes located in a rural census tract, regardless of where they delivered. For these patients, DAA prescription by 6 months increased from 24 to 91%, and known treatment completion increased from 14 to 64%. And while prescription did not increase at the main hospital, it did allow us to engage people earlier in pregnancy and offer them treatment options, and then arrange for treatment prior to labor and delivery. We were then able to focus those limited resources to get meds to beds at L&D on people who didn't engage in prenatal care in our health system and who only presented for delivery admission. And the numbers are small, but like at the main hospital, the treatment completion does seem to be trending towards higher. We still have room for
Madeline, just
improvement.
it's 8:49. Sorry, just letting you know.
Okay, yeah, yeah. We still have room for improvement with exposed infant screening, and only half of our infants were screened with perinatal transmission rates around 8 to 11%. But none of the perinatal transmissions happened in those who were treated antenatally. But that makes it like 2 out of 9 infants where treatment was deferred postpartum had a transmission. So this we have towards the ends of the study period with nurse navigators reaching out to infant caregivers and pediatricians to kind of facilitate screening, which would not have been captured in this data, but is kind of a next step for evaluation. That's all to say that there's multiple opportunities to engage women in Hep C care during and after pregnancy. There's antepartum, there's labor and delivery, and of course, there's the postpartum period. And each of these time points is an opportunity to engage people in care and try and improve treatment rates, women's health, and prevent further Hep C transmission. Some takeaways, to reach national elimination targets, we still need increased screening, diagnosis, and treatment. And so we need to get creative. And our programs kind of meet people where they are and where we already are. So it's not something completely new that we need to do. It's just kind of leveraging ongoing efforts. Emerging safety data for soft bowel and GP in pregnancy and breastfeeding are encouraging. Antenatal treatment may be prevention. And these interventions leverage encounters for other primary reasons to engage people in care. Our prenatal linkage to care program substantially increased DAA prescription and treatment completion across the health system. And this success was really driven by antenatal treatment. All were prescribed DAAs and 92% completed treatment. All right. What questions do folks have? I'm going to open the chat. Let's see.
Madeline, thank you. There was a few things, right? You made the comment about SVR4, which a few people agreed on. I think Laura answered the question as far as there was some FTE discussion, which if there's time, maybe we can talk about more. I feel like that's a very ID specific issue, and many of us are, but many of us are not. Um, Kathy asked about the insurance, and maybe one of you wants to talk about that more because I think that always becomes a big question. How does med to bed work if insurance won't cover the full course or requires filling at an outside pharmacy? Laura responded very well. I don't know if there's anything you'd want to add. Um,
Yeah, I mean, so most of our patients do have Missouri Medicaid, but we have a lot of patients that have Illinois Medicaid, and that has a refill and quantity restriction and requires various specialty pharmacies. And then there's a decent proportion of Medicare patients, like surprisingly. And so we face the same challenges with that as well. Um, we try and get the PA going while people are there, and then let patients and figure out which pharmacy it'll be and let patients know. And if we can't do that, we try and have close follow-up, like within a week or two, and get the labs going before they discharge. If we get the prescription sent, I I like to, and I think Laura does the same, see people at 4 weeks as like a reminder to myself to remind the patient to get their refill done. Um, and sometimes that doesn't happen. But
yeah, that was my
yeah.
question immediately. How many patients make those week 4 visits? Are they in person? Are they televideo?
Um, if it's coming from our pharmacy, I like to do it in person just because they can just get the medication right then. But really, like, it can be telemedicine. That's fine. I'm not doing anything. I'm just basically ensuring that they're getting their refill.
Right.
But I think more than anything, like, I'd say probably the no-show rate is pretty high. But uh, um, it then like reminds me to send a message to the patient or have my nurse call the patient. So our schedules are overbooked. We overbook for no-shows.
Sure.
Yeah, I think the biggest thing is that it just gives people an opportunity because if you then, because otherwise they wouldn't get the medication because you don't know who's going to coordinate the refill and who's not.
Okay. And then Aaron has a big question. And I don't know if Aaron, you want to unmute and do it. I know sometimes you don't have access to a microphone.
Can you hear me? I can try.
Yeah.
Yes.
Thank you very much for this presentation. I actually have two brief questions. One is, I'm blown away by the opening statistic that pregnant individuals are um, less likely to be receiving treatment. My initial thought is to break down system structures, but I'm wondering about psychologic structures. I treated a woman many years ago who was actively using crystal methamphetamines, was positive for hepatitis C, and she was pregnant. And my unconscious bias I brought into the encounter was to ask if she wanted to terminate the pregnancy or get assistance for anything like that. And she said, no, I want to have this baby. She's actually had two miscarriages prior, and she was afraid that if she went in for treatment for her stimulant use disorder or hepatitis C, that it would affect the pregnancy. And so I'm thinking about health literacy and the stress and the responsibility of the pregnant individual, if any of those psychologic factors could be contributing to why they are less likely to be uptake of Hep C therapy. Second question, I'll be quicker on this one. How does abortion access affect uptake of Hep C therapy? And when you're looking at the data of antepartum and peripartum uh, results of this, are those individuals who terminate their pregnancy removed from the data? And if they are, how does their Hep C treatment course differ? I think Missouri may have had recent changes in access to abortions. I don't know if any of that is affecting this data as well. Thank you.
Yeah, so I think psychological, so the reason why people aren't getting treated in pregnancy is because nobody's offering it. So that's one thing. And then postpartum treatment is just like nobody follows up for any postpartum appointments. And so that's why like it's just across the literature, like people don't even attend their postpartum OB visits. And so uh, I think that's one thing. In terms of psychological effect of Hep C and treatment in pregnancy, I think that's actually a real driver for uptake of treatment is some people have a lot of shame about their substance use and the fact that that's how they acquired Hep C, and they want to do anything they can to improve the health of that pregnancy and to prevent transmission. And so there's like this association with that. And there's a qualitative study, and we see this in non-pregnant individuals, but Hep C treatment can actually be very motivating. It's a defined course with a high success rate of cure. And so it's been shown in like non-pregnant populations to reduce ongoing substance use, to improve self-efficacy. And there was one qualitative study of women that were involved in the clinical trial. And it said that it made them feel like they could just like do better with other things, and it helped them like feel more empowered to like not use drugs and that. So I think it's offering treatment and having the opportunity for treatment is like a huge has huge potential, especially in the setting of pregnancy, which is already a motivator in general for behavior change. Um, uh, in terms of uh, abortion access. So Illinois, we're right on the border with Illinois. So at least for the folks that we see in our perinatal substance use program, they have to come in person. So they generally have a way to get to our clinic. Some of them do go on to get abortions in Illinois. We did not include those individuals in our data because we wanted to say something about treatment. We didn't want There was like one person who got a termination of the 35 patients at like 12 weeks. And in those cases, we offer them treatment after like postpartum or post termination. But they weren't included in that data because we didn't really feel like it kind of like reflected the cohort of like treating sort of in the second and third trimester.
Thank you. Um, Yeah, I was just asking. I know that we've emailed you about these logistical questions as far as
Yeah,
nursing, and it's not, I mean, the logistics matter so much, which is um,
yeah.
part of this. And we love hearing about it. I know that Kathy asked the question. We actually, we've done a few med to beds. I wanted to see that. I am looking at the whole group. Is anyone aware here at UCSD or just at other places within San Diego County where treatment in pregnancy is occurring? Because I'm not aware of that yet. Uh, while people are thinking, sorry, I jumped in so fast. I emailed a few of our ID doctors about this question, like our general ID questions, or general ID doctors to see if they'd gotten referrals for this. And they all said maybe one, like in the, like, so it's it's not happening a lot, at least within UCSD. I was about to actually, I think I finally removed the draft, but this is going to inspire me to do it. I was going to email our OBGYNs about what is happening with this because it seems like our seroprevalence would be a lot lower. We don't have a clinic like what you're describing. Ours would definitely be more at the Owen Clinic here at UCSD, which would be the one with a higher overlap. And I'm pretty sure they're doing all the testing in pregnancy. But those are people with HIV, right? So I don't know what it looks like outside of HIV. Does that
Yeah, and
make
I'm not
sense?
sure like what
Yeah.
your health system looks like either, because like probably about half of the pregnancies were like in St. Louis or like seeking care in St. Louis areas, and then half of them were really spread across many, many different locations, seeking care in like rural areas, and that's where like Um, I think these programs could have the most impact because they might not be seeing like high in like in a perinatal substance use clinic, like the incidence is really high, but like then how do you reach those people outside of that where there might not be anything robust because they just don't see it a lot. And so that's where I feel like these kind of proactive programs have had the biggest impact in providing support. Like in the notes, you'd see like refer to postpartum care, and then it would be mentioned. Like I didn't look to see if referrals were placed, but like it wouldn't be mentioned in any
Right.
notes anywhere thereafter.
Yeah, I think, and I realize it's after 9, people are dropping off, and maybe a few of us can do a call with you directly. But I think our
Yeah.
next step is speaking to our OBGYNs because I think we just don't have a sense of that volume. We have a focus program as well, so we're doing hepatitis C testing. In the hospital, there just aren't a lot of pregnant people coming up that are being
Mhm.
admitted to the hospital. So it has to be more outside. Of course, we don't here at UCSD have the big rural capture that you have. So. And then very quickly, 2 other clinics responded, San Isidro Health, and I'm sorry, I'm forgetting where Fernando is, but they said they're just not seeing it or they haven't done it yet in pregnancy. So I think this is a big new frontier for us, and we will speak to you as if we need to for assistance. Thank you so much.
Yeah, sounds great. Thank you so much for having me and Laura.
You both are amazing, and we're inspired by your work. So thank you.
Yeah. All
Okay.
right,
Fernando's
thanks.
at San Isidro too. Got it. All right. So 2 institutions, no pregnant people yet, but it's going to happen and we'll keep you posted.
Sounds
Thanks so
great. All
much.
right, bye.
Bye.